everyone. In continuation with the contraceptive devices, now I'm going to talk to you about IUCDs, that is intrauterine contraceptive devices, and we will be discussing in detail about the classification, about the mechanism of action, about the IUCDs which are approved by the Government of India and have been included in the National Family Planning Program. Then we will also talk about certain clinical situations, and a very important segment of this video is where I'm going to demonstrate to you how an IUCD is loaded and how it is inserted, right? So let's begin with the IUCDs. Now IUCDs, they are 3-generation IUCDs, first generation, second generation and third generation. First generation IUCDs are inert IUCDs, and an example of first generation IUCD is a Lippes loop, and Lippes loop, the first generation IUCDs, they are not being used these days. Then comes the second generation IUCDs. In second generation IUCDs, the important point is that they are all copper containing IUCDs. Example of second generation IUCD is copper T and multi-load devices. And then we have the third generation IUCDs, which is hormone containing, that is progesterone containing IUCD, and an example of that is Mirena. Right? Now, amongst the IUCDs, the one which have been included by the Government of India in National Family Planning Program are 2 IUCDs. Number one is copper T 380A, that is Paragard, and the one which has recently been approved is multi-load 375. Now, quickly, I'm going to take you through the details of copper T 380A, although I know this all has been covered so well in PSM by Dr. Mohit that I don't need to cover it, but for the sake of completion, I'm just going to take you through this very quickly. So, as the name suggests, it's copper T, right? So, copper means it will have copper wire wound around it, and T means it is a T-shaped device. So, as you can see in this image, this is a T-shaped device. Then 380. 380 stands for the area of copper wire which is present around it. So, 380 millimeter square is the area of the copper wire. Now, as you can see, typically in this IUCD, copper is present not only on the vertical stems, but it is also present on the arms. Whereas, when I'll show you this next IUCD, you will see copper containing IUCD. Copper is present only on the vertical stem, right? So, because copper is present on the horizontal arms, that is why it is copper T380A. Right, so this A stands for that the copper is present on the horizontal arms. Then you can see over here there is a small ball, and this small ball is 3 millimeter square ball which prevents uterine perforation. It prevents uterine perforation. Right? And there is a thread which is attached, which is a polyethylene thread. This is a monofilament, and feeling this thread is the way by which a female is going to know that yes, the copper T is in place. Now, this copper T 380A, which is also called as Paragard, right? And it is included in our National Family Planning Program. It releases 50 micrograms of copper per day, and it can release copper up till 12 years. Please be very careful over here. Copper can be released by Paragard till 12 years, but its approved lifespan is 10 years, right? Although it can release copper up till 12 years. Right? Then, as I was telling you, a recently included in the National Family Planning Program is multi-load device, that is multi-load 375. Now, typically, if you see over here, this is not a T-shaped device, right? So, it's not called as T, right? And it doesn't have any copper on its arm, so there won't be any A also, right? Now, a very important thing to note over here is that it has no copper on its arm. Yes, it is not T-shaped, and its arms are bent. If you see, the arms are bent. It is an umbrella-shaped device, and it has got these spurs, right? So, if you have to draw a multi-load device, this is how you have to draw it. You have to make spurs. Now, these, the arms which are bent and the spurs which are present on the arm, they are there so that expulsion of this device is less. right? And it has nylon thread. This thread which is present over here is a nylon monofilament thread, and lifespan of multi-load 375 is 5 years. Right? So these are the important points which you have to remember about multi-load. Mechanism of action of copper T and mechanism of action of multi-load, in fact, mechanism of action of all second generation IUCDs will be the same. So what is the mechanism of action of all second generation IUCDs? All second generation IUCDs are copper containing IUCDs, and they are going to release copper. Now when they release copper, they induce a sterile inflammatory reaction. Now because of this sterile inflammatory reaction, this reaction is sufficient enough to be spermicidal in nature, and hence fertilization doesn't happen. So if they ask you what is the main mechanism by which copper IUCDs act, please remember that mainly copper IUCDs act by preventing fertilization. That is the answer you have to look for. They prevent fertilization. Now, if this option is not given, be very, very careful. Best answer is it prevents fertilization. If this answer is not given, then you are going to say it inhibits implantation. Both these are actions of copper IUCDs, right? So for all the undergraduate students, you will have to write both of them. But when you have to choose one main mechanism, it is prevention of fertilization, which is a better answer than inhibition of implantation. Please remember that IUCDs, they never act by bringing about abortifacient. So copper IUCD. Copper IUCD is not going to bring about an ovulation, and it is not an abortifacient. It has no effect on ovulation, and it is not an abortifacient. Right? So the main mechanism is it prevents fertilization. Second main mechanism is it inhibits implantation, but it doesn't have any effect on ovulation, and it is not an abortifacient. Clear? Then, time of insertion of IUCD. Now, this is again very important, and this is a place where you tend to get confused. See, a female who has recently delivered, and if you have to put an IUCD, Government of India says that you can put IUCDs at 2 times in a female who's recently delivered. Either you can do it within 10 minutes of delivery. If you are doing it within 10 minutes of delivery, that is what is called as post-placental insertion. Or you can do it after 10 minutes, but within 48 hours of delivery. If you are inserting IUCD within 48 hours of delivery, that is what is a postpartum IUCD insertion. So if someone asks you, postpartum IUCD insertion can be done maximum up till what time? It can be done up till 48 hours after delivery. Now suppose up till 48 hours after delivery, a female did not get an IUCD inserted. In that case, you are going to wait now. After 48 hours, you cannot insert an IUCD. After 48 hours, you have to wait for 6 weeks after delivery. So, either you do it within 48 hours of delivery. If you have not done an IUCD insertion within 48 hours of delivery, then you will have to wait till 6 weeks after delivery. And if you are inserting an IUCD 6 weeks after delivery, that is what is called as interval insertion, interval copper T insertion. Clear? Now, a female who has not recently delivered, in that case, you can insert an IUCD within first 10 days of the cycle. Within first 10 days of the cycle. Why within first 10 days of the cycle? Because this ensures that the patient has not become pregnant, right? After 10 days, ovulation may happen any day, and it could be that the patient has conceived, right? So you have to do it within first 10 days of the cycle. If there is a female who has not delivered or she was not pregnant in the recent past, and you are putting an IUCD in her. Please remember, Government of India advocates postpartum IUCD insertion. Postpartum IUCD insertion. So Government of India says that you should, motivate a female who's delivered to go for postpartum IUCD insertion, right? Then comes the risk of PID, another very, very controversial area over here. See, when studies were done, initially a few studies showed that yes, the risk of PID is increased with IUCD. But when these studies were carried on for a long time, it showed that the risk of infection with IUCD does not increase with long-term use. The risk is only in the first month of insertion, and that too in first 20 days. Maximum risk is in the first 20 days of insertion, and we as practitioners can reduce that risk by taking proper aseptic precautions while loading the IUCDs, right? Then please remember, past history of PID is not a contraindication. It is not a contraindication for IUCD. Present history of PID, yes, it is a contraindication for IUCD. Now, any female who is at risk for, sexually transmitted diseases, PIDs. For example, if there is a female who has multiple sex partners, or if she's not in a very stable relationship, or suppose if she's a drug abuser or alcohol abusers, we do not prefer to use IUCDs in such females. But then if such females are using IUCDs, you have to advise them that along with IUCDs, they have to use a barrier contraceptive. So same is the case with HIV patients. In HIV positive females, to prevent pregnancy, best contraceptive device is IUCD. But to prevent the transfer of infection, to prevent the transmission of infection to the other's partner, then best is barrier method. So when we say which is the best contraceptive in an HIV positive female, we are not worried, as a contraceptive, best is IUCD, right? But yes, to prevent the infection from transmitting to the partner, then you use, along with IUCD, you use a barrier method. Same is over here. If you have a high-risk female who has multiple sex partners, who's not in a stable relationship, or who is a drug or an alcohol abuser, it's better that along with IUCD, you use a barrier contraceptive. Right? Now, if I ask you, and I'm sure you all know the answer to this question, that which is the most common PID in a female who's using IUCD, most common is actinomyces. Actinomyces. That's the most common PID, and suppose actinomyces has been detected in a female who's using IUCD, then the management is you have to give penicillin G 500 mg QID for 1 month. Now, as I was telling you that as practitioners, we can reduce the risk of PID by properly handling the IUCD while inserting. So what is the method of insertion? So method of insertion of IUCD is, please, you have to use a no-touch method. No-touch method. And just now I'll show you how to load an IUCD without touching it, right? And a withdrawal technique. Withdrawal technique. Clear? Then, let's talk about the risk of ectopic pregnancy, again a controversial area. Now, when we are talking about the absolute risk of ectopic pregnancy, since IUCD is a contraceptive device and with very good, effective rate, Pearl index is very good. Right? So it is very effective in preventing all types of pregnancies, including ectopic pregnancy. So if someone asks you what is the risk, absolute risk of ectopic pregnancy while a female is using IUCD, the absolute risk is decreased with IUCD because it decreases risk of any type of conception. Right? But then if IUCD failure happens and then a female has conceived due to IUCD failure, then the pregnancy which is going to occur would be ectopic pregnancy. So the relative risk of ectopic pregnancy is increased if failure of IUCD happens. right? So if pregnancy is a result of failure of IUCD, then the relative risk is increased. Clear? Now, if I ask you, keeping this fact in mind, that ideally the chances of ectopic pregnancy are decreased with an IUCD, right? So tell me, do you think previous history of ectopic pregnancy will be a contraindication for use of IUCD? No. Right? So this is again one very important thing which you have to remember. As I have told you in the video on oral combined pills also, please do not go by what Park has said. Park has not been updated since a long time. For contraception, you have to rely solely on Leon-Spiroff, and since I am referring to Leon-Spiroff, whatever I am teaching you in contraception, just believe me and, learn whatever I am teaching you in contraception. Have faith in me that I am teaching you, whatever I am teaching you is from Leon-Spiroff, and that's what you have to follow. Right? So, history of ectopic pregnancy, it is not a contraindication for use of IUCD. So, previous history is not a contraindication. That's very, very important thing which you have to remember. So, if I ask you copper IUCD, in which cases do you think is a copper IUCD contraceptive of choice? So, copper IUCDs are contraceptive of choice in diabetic patients, in stable heart disease patients, right? And in HIV positive females. As I told you, in HIV positive females, to prevent transmission of HIV, you are going to use barrier. But for contraceptive, the best is IUCD. Right? What is the most common side effect of IUCD? Most common side effect is bleeding. But most common cause of removal of IUCD is pain. When does fertility return after removal of IUCD? Immediately. Return of fertility is immediate after you remove IUCD. Right? Now, my next question. Can IUCD be used in a nulliparous female? Yes. IUCDs can be used in a nulliparous female. In a nulliparous or in a nulligravida female, it's better to use frameless IUCDs because they are going to cause less pain and the expulsion rate will also be less. And for these frameless IUCDs, we have two types of frameless IUCDs, Gynefix, which is also called as Copperfix or FlexiGuard. Now, this Gynefix, it has got 6 copper sleeves, and these 6 copper sleeves, look over here. So in this image there are 4, but in the one which is available in India, it has got 6 copper sleeves or copper cylinders, and these 6 copper cylinders, they are present on a string, and one end of the string is knotted. Right? So one end of the string has a knot. Now what we do is this frameless IUCD, which is Copperfix, it has to be sutured onto the myometrium. And these 6 copper sleeves, they have got copper 330 millimeters square of copper. Right? So a frameless copper IUCD is Copperfix, Gynefix or FlexiGuard, and a frameless levonorgestrel IUCD is a fibroplant, right? So it is a levonorgestrel containing frameless IUCDs. Now, this levonorgestrel containing frameless IUCDs, it is either there are 2 types of these fibroplants which are available. Some fibroplants, they release 14 micrograms per day of levonorgestrel, and some companies, the ones which are available, they release 20 micrograms per day. More common is the 14 microgram per day releasing fibroplant, right? Now, fibroplant is not just used in a nulliparous or a nulligravida female. It is also used in perimenopausal females or menopausal females. Now, as you know, that because progesterone has anti-proliferative activity, right? This is something which we've been doing from such a long time. So, because progesterone has anti-proliferative activities, so progesterone-containing IUCDs are used for management of endometrial hyperplasia without atypia, right? So, if there is endometrial hyperplasia without atypia in a perimenopausal or a postmenopausal female, then I have to use a progesterone containing IUCD, and instead of using Mirena, I am going to use a fibroplant. Similarly, if I have a female perimenopausal or a menopausal female who's come to me with menorrhagia and I have excluded malignancy, then in them also I can use a fibroplant, right? Because this is a frameless levonorgestrel containing IUCD and it has a shorter duration of action, right? It has a shorter lifespan in comparison to the Mirena. Clear to all of you? Yes? Okay. So this over here is a fibroplant. This is an image of fibroplant. This is an image of Gynefix. Now, case 1, very interesting case. Suppose you have a female who comes to you and she says that there is missing thread, right? She tried to feel her threads while she was taking shower, but she cannot feel her threads. Now, what are the possibilities if a female comes to you with this complaint that she cannot feel her threads? Number 1 possibility could be that the thread has coiled up. Right? That could be one possibility. Second possibility could be that this female has conceived and so the size of the uterus has increased and that is why the thread is not being felt. Third possibility could be that the copper T has perforated the uterus and that is why now the thread is not being felt. And fourth possibility could be that the IUCD has been expelled. Right? So let's deal with each of the possibility and what is the next step in them. So if a female is coming to me with missing thread and I ask you, tell me what is the first step which you should take whenever a female comes to you with missing thread. Please remember that the first step has to be a TVS. Most of the times the IUCD would be visible on a TVS. But suppose they say that on TVS the IUCD is not visible. Then what is the next step? Then the next step is you should do serial abdominal x-rays. Go for serial abdominal x-rays. When you do serial abdominal x-rays, because copper T's or any intrauterine contraceptive device is radio opaque, you will be able to see in any one of the films. Right? So yes, the first investigation which you have to do whenever a female comes to you with missing threads is TVS. And if on TVS you cannot see the IUCD, then you should go for abdominal X-ray. Right? Why I'm not saying that X-ray is the first thing? Because I told you there is a possibility of the female having conceived or the female becoming pregnant. That is why I am not saying that the first is abdominal X-ray. First is ultrasound. Right? Now suppose I did an ultrasound and I saw that the thread is coiled. So if the thread is coiled and the female says no, she's not very comfortable in using an IUCD with a coiled thread because she will always have this fear that she might have conceived. And she says, I want to remove the IUCD, then it's okay. You can remove the IUCD. You are going to remove IUCD under hysteroscopy using a Schroeter hook or an artery forceps. And otherwise, you can also use a hysteroscopic grasper to remove the IUCD. Or if she says, no, I'm okay with the coiled thread and I want to continue the IUCD, she may continue. It's totally upon the patient's wish. If she wants to continue with IUCD, she can continue. If she says, I want to remove it, so under hysteroscopic guidance, you should be removing it. We use a grasper to remove with the under hysteroscopic guidance, or you may also use a hook or an artery forceps. Right? The second possibility is that perforation has happened. Now, if perforation has happened, an IUCD is in the peritoneal cavity. Now, if IUCD is in the peritoneal cavity, you will have to do a laparoscopy to remove the IUCD because this IUCD is going to release copper and that copper is going to lead to adhesions. So, in that case, I will have to do a laparoscopy, or if already adhesions are present and laparoscopy is not possible, then I may also go for laparotomy. Depending upon the surgeon's expertise and depending upon how many adhesions are you expecting there, right? Then, suppose IUCD is partly inside the uterus and partly inside the peritoneal cavity. In that case, you will have to go for hysteroscopy plus laparoscopy. Clear? The third possibility is that patient has conceived while IUCD is there in place. Now, if patient has conceived and the IUCD is still there, management depends upon whether the patient wants to continue with the pregnancy or whether she doesn't want to conceive. Please remember, IUCDs are not teratogenic. So if patient asks you for an advice that can I continue? Yes, she can continue, right? Because IUCD is not teratogenic, number one. But then on the other hand, you will also have to make the patient aware of complications which might happen if we are unable to remove the IUCD and she continues with the pregnancy. What are the complications which can happen if IUCD is still there and pregnancy is being continued? So the complications which can happen if IUCD is in place and pregnancy is being continued is, number one, infections. Right? And this infection, obviously, infections can lead to abortions, infections can lead to preterm labor, premature rupture of membranes, and IUGR. Right? So there are increased chances of abortions, infections, preterm labor, premature rupture of membranes, and IUGR. Right? This is if IUCD is in place and she's continuing pregnancy. Right? Now, suppose I will tell you just now what you are going to do if patient says, I want to continue with pregnancy. First, let us take up this case scenario that patient says, no, I do not wish to conceive. I don't wish to continue pregnancy. In that case, it's okay. Remove the IUCD and proceed with the MTP. But suppose patient says that, no, I want to continue pregnancy. Best is that IUCD should be removed and then pregnancy should be continued. So if thread is visible, remove the IUCD, tell her that since the IUCD is removed, the chances of abortions, chances of infection have become less. Right? But suppose IUCD is not visible and still she wants to continue with the pregnancy, she may continue with the pregnancy. Right? And in that case, yes, the chances of abortion, chances of preterm labor, premature rupture of membrane, infections, and IUGR is there. Clear to all of you? So this is how you manage if a patient becomes pregnant with IUCD in place. Clear? Okay. Now, I have talked to you about copper IUCDs. Now, let us talk about the third generation IUCD, which is levonorgestrel IUCD, and the one which is available in India is Mirena. Now, Mirena is a third generation IUCD. It does not contain copper. It contains progesterone levonorgestrel, and the total amount of levonorgestrel which is present in Mirena is 52 milligrams. Out of this 52 milligrams of levonorgestrel, this Mirena, it releases 20 micrograms of progesterone or levonorgestrel per day, and that is why it is also called as LNG20. Like copper T380A was called as Paragard. So similarly, Mirena, the other name for Mirena is LNG20. Right? Now, as I was telling you that copper T is capable of releasing copper till 12 years, but its lifespan, which is approved, is 10 years. Similarly, Mirena can release levonorgestrel till 7 years, but its approved lifespan is 5 years. Now, if you have to recognize Mirena in images, as you can see, there is no copper over here. It is an intrauterine copper device which doesn't have any copper. So, an intrauterine contraceptive device which doesn't have any copper is a Mirena. Now, these days, we also have two newly approved hormonal IUCDs, and these two newly approved hormonal IUCDs are just the names you need to remember and few details. One is Lilita and the other is Skyla. Now, in Lilita, its composition is similar to Mirena and it can be used up till 4 years. So, Lilita is similar to Mirena, but its use is approved till 4 years, right? But yeah, studies are still going on to see that can it be used for 5 years, but approved lifespan is 4 years. And the main difference between Mirena and Lilita is its low cost. Lilita, low cost. Then there is Skyla. Skyla has 13.5 milligrams of levonorgestrel and it is approved for 3 years. So Skyla is for 3 years, Lilita is for 4 years, and Mirena is for 5 years. Lilita and Skyla are the two newly approved levonorgestrel devices by the FDA, right? What is the main mechanism of third generation IUCDs? Main mechanism of third generation IUCDs is that they prevent implantation. right? So main mechanism for copper T was it was preventing fertilization. Main mechanism for Mirena, although this is a progesterone containing IUCD, please do not say that it brings about an ovulation. No, Mirena doesn't bring about an ovulation. It prevents implantation. That's a very, very important question. Right? The most common side effect for Mirena, similar to other progesterone-containing IUCDs, is irregular bleeding. But when you use Mirena for continuous, when you are continuously using Mirena, what happens is because of the anti-proliferative effect of progesterone, there is endometrial atrophy and ultimately it leads to amenorrhea. And that is why Mirena has got many non-contraceptive benefits. The non-contraceptive benefits of Mirena, they are because of the three effects of Mirena. Number one, because it will decrease blood loss, menstrual blood loss. It is a progesterone-containing IUCD. When you are going to give progesterone, progesterone is going to stabilize the endometrium and so menstrual blood loss will decrease. So one non-contraceptive benefit of a set of non-contraceptive benefits of Mirena can be explained because it decreases menstrual blood loss. Number two, its non-contraceptive benefits are due to its action of because of its anti-proliferative action on endometrium. Now, because progesterone, when used continuously, they bring about endometrial atrophy. So, a set of non-contraceptive uses are based on this action. The third set is based on the action that all of you know, progesterone, they make the cervical mucus thick. So, since Mirena is a progesterone, and yes, the main mechanism of action is it prevents implantation, but because it has got progesterone, it will also make cervical mucus thick, right? So a certain non-contraceptive benefits of Mirena are because it makes cervical mucus thick. So if I ask you what are the non-contraceptive benefits of Mirena, so remember these three effects and you will come to, you will recall all the non-contraceptive benefits of Mirena. For example, as I was telling you, a set of non-contraceptive benefits is related to its effect of decreasing blood loss. So definitely Mirena can be used in management of atypical uterine bleeding. It can be used for management of fibroid bleeding. It can be used for management of menorrhagia in case of adenomyosis. Right? So in all these cases, wherever there is excessive blood loss, you can use Mirena. Then because it has anti-proliferative action, it can be used in management of endometrial hyperplasia without atypia. It can be used in management of endometriosis. In management of endometriosis, I told you that you can use progesterone because progesterone has anti-proliferative effect, right? So it can be used in management of endometriosis. It can be used for preventing endometrial cancers. So if a female is on tamoxifen therapy or if a female is being given HRT and you want to protect the endometrium from estrogen only effect, then you can also use Mirena for that purpose. So yes, it can be used for managing endometrial hyperplasia, it can be used for managing endometriosis, and it can be used for preventing endometrial cancer from happening. Now, because Mirena makes cervical mucus thick, it can prevent PID also. Right? Now, if I ask you, do you know of any non-contraceptive benefit of copper T? Yes, there is one very important non-contraceptive benefit of copper T, although I will not call it as a non-contraceptive benefit, but yes, it is one very important advantage of copper T over Mirena is that it can be used as an emergency contraceptive. Mirena cannot be used as emergency contraceptive. Very, very important thing which you have to remember, that copper T can be used as an emergency contraceptive, and an emergency contraceptive, I'm going to tell you that copper T is the most effective emergency contraceptive, right? Whereas Mirena cannot be used for emergency contraception, although levonorgestrel tablets are used as emergency contraceptive. But Mirena cannot be used as an emergency contraception. Right? Number one. Number two, in case of Asherman syndrome, if you want to prevent adhesions from happening after you've done adhesiolysis and you do not have a pediatric Foley's catheter and patient also doesn't want any conception, so in that case, you may use copper T. Right? So to prevent adhesion formation after adhesiolysis or after septum dissection, you may use copper T. So these are non-contraceptive benefits of copper T. Is that clear to all of you? Right. So one very important difference between copper T and Mirena, I told you, was that copper T can be used as emergency contraceptive. Mirena, it cannot be used as emergency contraceptive. The second very important thing which you have to remember is about the risk of PID. Just now I told you Mirena decreases the risk of PID. Why? Because it makes cervical mucus thick. Right? Whereas, when we talk about copper T, I told you just now, copper T increases the risk of PID in first 20 days. Right? And the most common PID which happens after the use of copper T is actinomyces. Similarly, if we are comparing the risk of ectopic pregnancy, as I told you, the absolute risk of ectopic pregnancy is decreased with any IUCD. Right? So the absolute risk is decreased with any IUCD. Right? But if failure occurs, this is common sense that if failure occurs with Mirena, Mirena is a progesterone-releasing IUCD and progesterone relaxes the smooth muscles. And one of the reasons why a morula is going to move from the fallopian tube to the uterine cavity is due to the peristalsis of the tubes. And because Mirena is releasing progesterone is a smooth muscle relaxant, so the peristalsis is going to decrease. And because peristalsis is going to decrease, if failure of Mirena happens, then the chances of ectopic pregnancy are more. So with Mirena, the chances of ectopic pregnancy are more in comparison to copper T. Clear to all of you? Yes. PID, the chances are more with copper T in comparison to Mirena. But ectopic pregnancy, chances are more with Mirena in comparison to copper T. Another point of difference is blood loss. When we are talking about blood loss, copper T is going to increase the blood loss, whereas Mirena decreases the blood loss. Right? And that is why Mirena has so many non-contraceptive benefits, including its use in atypical uterine bleeding. Right? If we compare failure rates, now when you are comparing failure rates for typical use and perfect use, most of the times they are very similar because they are not dependent upon the patient. So in copper T, the failure rate with typical use is 0.8 100 women years. With perfect use, it is 0.6. With Mirena, it is 0.2 with typical use and 0.1 with perfect use. Right? Now, how should you dispose an IUCD? IUCD should be disposed in a red bag. And what is the minimum hemoglobin which should be there for a patient to use IUCD? Minimum hemoglobin should be 7 gram%. This is if you are using copper T, because copper T increases blood loss. So minimum hemoglobin which I want if a female is using copper IUCD is 7 gram%. But then if hemoglobin is less than 7 gram%, that's not an absolute contraindication to use copper T. But I would prefer to use copper T in females whose hemoglobin is more than 7 grams%. Right? Now, what are the absolute contraindications to IUCD? And when I'm saying IUCD, it is copper IUCD plus Mirena. Now, these contraindications are called as WHO Category 4 contraindications, and they include undiagnosed vaginal bleeding, number 1. Number 2, distorted uterine cavity. Distorted uterine cavity. Now, this distorted uterine cavity can happen with fibroid, it can happen due to cancer endometrium, it can happen due to cancer cervix, or it can happen due to congenital anomalies of the uterus. right? So a distorted uterine cavity. Number 3 is current pelvic inflammatory disease. So if presently your patient has got any pelvic infection, that's a contraindication. And obviously, if it is a case of suspected pregnancy. Now, all of you undergraduate students, you have this tendency of saying pregnancy first in contraindications. Please remember, obviously, in pregnancy, a contraceptive agent would be contraindicated. So you are not going to say pregnancy as the first absolute contraindication. Take it to the last, right? So the first absolute contraindication is undiagnosed vaginal bleeding. Then you are going to say distorted uterine cavity, current pelvic infections. And if your examiner says more, any other, if they are saying like this, then say yes, suspected pregnancy. Now, a contraindication which is there only for Copperty and not for Mirena is Wilson's disease. And a contraindication which is only for Mirena and not for Copperty is history of breast cancer. History of breast cancer. So this is all what I want you to know on intrauterine contraceptive devices. But before we end, I want to show you a video on how to load a Copperty and how to insert it in a patient. That's very, very important skill which all of us should be knowing. Even if we are MBBS graduates, still it is something which you should be knowing. So let's have a look at that. Hi students, now we've come to that part of the video where I'm going to tell you how to load an IUCD, and I'm going to show you how you are going to insert it into your patients. Now, before I start the demonstration of how to load and how to load the IUCD and how to insert it in your patients, it's very important for you to know the instruments which are used for IUCD insertion. Now, if you are an undergraduate student, this becomes very important because in your table viva, you could be asked that. You could be asked to separate all the instruments which are used for IUCD insertion. And if you are a NEET PG aspirant, then I hope you remember in NEET PG 2021, there was a question where you had to, find out all the instruments you needed for cesarean section. So there were a lot of options which were given, and you had to, correctly identify which instruments are needed for cesarean section. So if you could be given a question on instruments of cesarean section, definitely you could be given a question on insertion of IUCD as well. So let me tell you what instruments are needed for IUCD insertion. See, I will be able to do an IUCD only if I do a per speculum examination. And whenever you have to do a per speculum examination, you need, the first instrument which you need is a Sims speculum. This in my hand is a Sims speculum. Sims speculum is a non-self-retaining speculum. It is double-bladed, right? And it is used for retracting the posterior wall of vagina. So with the help of Sims speculum, I am going to retract the posterior wall of vagina. Once I have retracted the posterior wall of vagina, I have to retract the anterior wall of vagina. To retract the anterior wall of vagina, I am going to use the anterior vaginal wall retractor. Now, there is a video which I have given on YouTube on Marrow channel, which deals with all instruments in obs and gynae. That's a very, very important video for you. Over here, I'm just telling you that how are you going to identify the anterior wall, vaginal wall retractor. As you can see over here, it has got 2 loops, right? And these loops, they have got serrations or fenestrations ahead, right? So both the ends, there are loops with fenestrations present. So this over here is an anterior vaginal wall retractor. So with the help of Sims speculum, I'm going to retract the posterior wall of vagina, and with the help of this anterior vaginal wall retractor, I'm going to retract the anterior wall of vagina. Now I have to hold the anterior lip of the cervix, and to hold the anterior lip of cervix, I can use any of these 2 instruments. Now the instrument which is there in my left hand over here is a valsellum. Now, a valsellum over here, as you can see, posteriorly, it has a ratchet which is present. In the anterior part, it has a concavity which is facing upwards, and there is space between the blades. Now, when I'm going to open the blade, you are going to see that it has got rat-like teeth, multiple rat-like teeth which are present on both the ends. Right, so it helps in grasping the anterior lip of the cervix. Now this over here is a valsellum, and whenever you have to apply a valsellum to hold the anterior lip of the cervix, the concavity should be facing upwards. So you can also use a tenaculum to hold the anterior lip of the cervix. Now if you look at the tenaculum, a tenaculum also has a ratchet at the posterior, a ratchet lock at the posterior end, and anteriorly between the blades you are getting space. Now when you open the tenaculum, it is single toothed. Can you all see the single tooth over here? Yes. So either you can use a tenaculum or you can use a valsellum. Anything can be used to hold the anterior lip of the cervix while you are inserting copper T. The only advantage of using valsellum is that bleeding will be a little less in comparison to this sharp tooth tenaculum. As far as post-procedural pain is concerned, it's almost same whether you use a tenaculum or whether you use a valsellum, right? Now, after I have held the anterior lip of the cervix, the next thing which I have to do is I have to see the length of the uterine cavity, and in order to look at the length, to measure the length of the uterine cavity, I am going to use a uterine sound. Over here, I have two sounds in my hand. One of them is a bladder sound and the other is a uterine sound. How are you going to identify which is a bladder sound and which is a uterine sound? So look over here very carefully. The sound which has got an angle like this. Can you see a very sharp angle? Yes. So the sound which has got an angle like this is uterine sound, number one. Number two, in a uterine sound, look at the tip. Can you look at the tip? This is olive tipped, whereas the tip of the bladder sound is not an olive tip. And the third and the most important way in which you can differentiate between a uterine sound and a bladder sound is a uterine sound has markings. It is calibrated, right? Whereas a bladder sound doesn't have any markings. So I'm just showing the uterine sound to you so that you can appreciate its angle. Yes, you can appreciate the markings. It is calibrated. When you're going to hold it in your hands, you're going to see calibrations are present and it will have an olive tip, right? So this in my hand is a uterine sound, whereas this now in my hand is a bladder sound, right? So with the help of this uterine sound, I have to measure the length of the uterine cavity. And then once I have inserted the copper T, I will need a scissors, a pair of scissors, so that I can cut the thread of copper T. So these are all the instruments which you would be needing for inserting copper T. Now let me show you how you are going to insert copper T and how you are going to load copper T with the help of a video. I'm going to show you how an IUCD is inserted. Before you start inserting an IUCD, you have to do a thorough pelvic examination in which you have to see that there is no undiagnosed vaginal bleeding. There shouldn't be any pelvic, infection, and there shouldn't be any uterine cavity distortion. Because if any of these is present, then that's an absolute contraindication for inserting IUCD. Once you've done a thorough pelvic examination, you have to do cleaning and draping of the part, and the patient's position should be in dorsal lithotomy position. No anesthesia, no analgesia is required. And once the patient is in dorsal lithotomy position, I have cleaned and draped the part. And now I am going to do a per speculum examination. Now, in this video, you can see that a Sims speculum has been placed so that the posterior wall is retracted. The anterior vaginal wall retractor has been placed so that the anterior vaginal wall is retracted. And now I am using a valsellum to hold the anterior lip of the cervix. Once this is done, I'm going to take a uterine sound and I am going to measure the length of the uterine cavity. So now you're going to see that we are going to measure the length of the uterine cavity with the help of a uterine sound. So once I have measured the length of the uterine cavity, approximate length I am going to tell to my assistant. Now my assistant is going to load the copper T. For loading of copper T, first you have to understand what is present in the packet of copper T. In a package of copper T, three things would be present. Number one, there will be copper T 380A, as you can see. Number two, you can see a transparent rod. This transparent rod is the inserter which has got this blue color depth gauge. And then you can see this white colored plastic rod, which is the plunger. And it has got a thumb rest. So all these three things are present in the packet of copper tea. Now, one very important thing which you have to remember is that chances of infections are maximum while you are inserting the copper tea. So there is a no touch technique. You don't have to touch the copper tea while you are loading it. So now I'm going to show how to load a copper tea without touching it. Now you're going to open the packet of copper tea very carefully. Please do not open the complete package, open it halfway. With your fingers, hold the horizontal arms of the copper tea and squeeze it. With the other hand, pull the inserter rod a little back and hold the inserter rod in a pencil-like manner. Once you've held the inserter rod in a pencil-like manner, now again move it forward so that both the horizontal arms, they slip inside the inserter tube. Can you see both the horizontal arms have slipped inside the inserter tube? This is how loading of copper tea is done without touching it. This is the no touch technique. Now once I've done this, I have to adjust the length of the inserter rod equal to the length of the uterine cavity or equal to the depth of the uterine cavity. So for that we have this blue colored gauge, which is also called as the flange. Now what I'm going to do is, see, on that sheet which is there, the white colored sheet which is there, it is calibrated. It has got markings there. Now suppose when I measured the length of the uterine cavity, it was 8 centimeters with the help of uterine sound. Now what the assistant is going to do, the assistant is going to pull the loaded inserter back in such a manner that this blue colored flange, it lies at the 8 centimeter mark. Now once this flange is lying at the 8 centimeter mark, you are going to hold it or stabilize it with your thumb. And now again you are going to move the inserter rod in front so that now the tip of the copper tea is coinciding with the tip of that packet which is there. Right? On that packet, on that white colored packet or one white colored paper or sheet which is present there, an IUCD is made. So the tip of your loaded IUCD, it should coincide with the tip of the drawing of IUCD which is made on that sheet. Right? So let's see, have a look at this video. So have you seen the loading of copper tea? This is loaded copper tea. Now what I'm going to do is I am going to withdraw the loaded IUCD's inserter a little back so that the flange is lying at 8 centimeter mark. I'm stabilizing it with my thumb and now I am pushing the raw inserter and the loaded IUCD again in front. Right? Now with my other hand, I have taken the plunger and after stabilizing the IUCD, now I am going to put this plunger inside the inserter rod. So this is how loading of copper tea is done. Now I'll let you know how you have to insert copper tea. Now this loaded IUCD which is there in the inserter and the plunger, it will be taken inside the uterus such that this blue colored gauge is lying at the level of external os. Now once this blue colored gauge or flange, it lies at the level of external os, I'm going to stabilize the tenaculum and I'm going to stabilize the plunger and slowly I am going to withdraw the inserter. Now the moment I withdraw the inserter, the arms of the copper tea are going to come out and my copper tea would be inserted. Then I'm going to cut the threads and that is all. So have a look. So now this loaded copper tea, I am going to take it inside the uterus so that the blue colored flange, it lies at the level of external os. Once it is at the level of external os, I have just withdrawn the tube, the inserter and not the plunger initially. Later on, the plunger also and the threads were cut. So that's a very, very easy procedure, insertion of copper tea. And as an, medical profession graduate, as a medical graduate, all of you should be aware of how to put or insert an IUCD. Now, in the next video, I'm going to show you how a misplaced IUCD can be, located with the help of hysteroscopy and how you can remove it. So now in this video, I'm going to show you a case of a female who was gravida 2, parity 2 and who got an IUCD inserted. and later on she couldn't feel her threads, and when we did an ultrasound we saw that the copper T was going inside one of the cornua of the uterus. So if it was blocking one of the cornua of the uterus, that's not how ideally a copper T should be placed. So we had to remove it hysteroscopically. So I'm just going to show how a hysteroscopic removal of an IUCD, a copper T, is done. So look over here. Now, this is the hysteroscopy being performed, and I'm sure by now you all know that how a hysteroscopic image of uterus looks inside. And as you can see, the copper T. Now, on one side, the copper T is placed properly. The ostia is open. But on the other side, now look over here. At this side, can you see that the arm of the copper T is going inside the ostia? Yes. Now, because the arm of the copper T is going inside the ostia, I will have to remove this copper T. So, simple instrument, that is a hysteroscopic grasper. I have taken a hysteroscopic grasper and I have gradually dislodged the arm from the ostia. Once the arm has been dislodged from the ostia, now I am going to slowly and gradually take out the copper T with the help of this hysteroscopic grasper. Clear?